Welcome to the webinar, Talking to Patients About Substance Use Disorders. I'm Barbara Lewis, the Managing Editor of .com, which is an online communication skills learning system for medical schools, residency, PA, and NP programs, and hospitals, now that .com offers over 40 CME credits. Joining me today is Dr. Barbara Schindler. She is the author of .com's Module 30, the Clinical Assessment of Substance Use Disorders. Welcome, Barbara.
Thank you. Very happy to be here.
Yes, and we're delighted to have you talking about this very important subject. Tell us a little bit about your background.
Okay, well, I've had a fairly long and varied career, but started out after training in psychiatry as a consult liaison psychiatrist and spent the first 20 or so years of my career actually working in a general medical hospital. It was during that time that I became very interested in how medical professionals work with patients who have substance use disorders, and frequently got called to do psychiatric consults on those patients. The very first study I ever did was actually about patients with bacterial endocarditis and opioid addiction who were coming into the hospital and frequently signing out against medical advice despite the fact that they had a very serious life-threatening illness, bacterial endocarditis. And over the years, got very involved in working with women who were delivering substance-exposed babies on the maternity service, and as a result of that, almost 30 years ago, started an addiction treatment program for women called Caring Together, where we work with women and their children who are hopefully in recovery from substance use disorders. That's kind of where I am now. I spent about 18 years, actually 20 years of my career in academic administration. For 2 years, I was an interim chair of the psychiatry department at what is now Drexel College of Medicine, and then spent 18 years as the academic dean at Drexel.
Mm-hmm. Well, before we get started, let me just say a couple of things here. First of all, the webinar is going to last 30 minutes. The recording and the PowerPoint will be available on .com website very shortly. If you have any questions, you can type them in the chat box that is located in the panel, usually to the right side of your screen. And if we don't have a chance to get to your question during the webinar, we will respond afterwards. So let's get started, Barbara.
Sure. Okay. Well, there were a couple of things I wanted to cover this afternoon. Let's start with defining the role of healthcare providers in the assessment of substance use disorders in their patients, because that's, that healthcare providers are a key, absolutely important key to being able to make those identifications and help then move patients from that point on to getting the necessary treatment if they need it. I wanted to talk some about the skills that we all need to conduct an unbiased clinical interview with patients that have substance use disorders. There are many challenges that we face in the clinical assessment of substance use disorders, so we really want to talk a little bit about that. Spend some time talking about medical and psychiatric comorbidities, because those are very high, much higher than in the general population in patients with substance use disorders. One of the things that's very important is to be able to ascertain whether people are ready to get help, where they are and they're thinking about change. And this comes up on a routine basis, even in the patients that I'm currently treating. And then to feel comfortable knowing how to make the referrals that need to happen to provide ongoing treatment, because we're talking about a chronic illness that will need long-term treatment, much as we talk about diabetes and hypertension needing long-term treatment. So I think we can go to, yes, thank you, the next slide. So, we've all been very concerned about the opioid epidemic, and here in Philadelphia last year, in 2017 at least, 1,271 individuals actually died, more than twice as many from gunshot wounds in the city. And so the concern about the opioid epidemic is very real, and, the federal government is playing a role at this point in trying to provide support. And in fact, we were fortunate to recently get a grant to develop a center of excellence at Drexel in opioid use disorder, which includes a lot of of training for our medical staff in terms of identification, many of the things that we're talking about today. So I don't have to go over these numbers with you. They're pretty startling, and these are 2016 numbers, so the 2018 numbers have really increased semi-dramatically, I guess. But if you have to look at the positive side of the opioid epidemic, I guess it's that it's really gotten a lot of people to pay attention to safe prescribing as well as how to intervene in the medical community with patients who have substance use disorders. So talking to patients about substance use disorders is not easy. It's a real challenge, and I'm sometimes challenged with all the years of experience that I've had in, saying the right thing to patients in order to engage them and help them talk about their substance use and what needs to happen next. I spend a fair amount of time teaching medical students, and particularly around communication skills, and I'm still surprised that in a clinical setting or in an exam setting, students will still say to patients, "You don't do drugs, do you?" And when they say no, which of course they're going to say when you ask the question that way, they answer, the student answers good. So, we have to really look at how we train people to ask the questions, and how you communicate with your patients is really critical. As I said, the opioid epidemic has really created a renewed focus, but the opioid epidemic's not the last epidemic. I've lived through probably 3 epidemics at this point, including the prior opioid epidemic, and now, and then later the cocaine epidemic, and now this new opioid epidemic. And I think benzodiazepines are probably going to be part of the next epidemic, whether it'll be alone or along with something else. And again, we as healthcare providers play a role because we're the ones that do the prescribing. So it's really important to ask the questions. It's hard, as I said. How did you learn about substance use disorders, and how did you learn as trainees to take a substance use disorder history? One of the things that, I have a soapbox issue is that we've trained most of physicians to think about the substance use history as part of the social history rather than the medical history. We have no trouble asking about hypertension and diabetes and cancer in the patient's history, as well as asking about family history of those illnesses, but we rarely ask the questions about the substance use history. So we have to really rethink about where that belongs. And I would add the psychiatric history as well needs to be in the general medical history. We've also had role models. Some of them have been positive, but a lot of them have been negative. And we continue to see those in the healthcare environment. And then because we've been burned, with patients that have struggled with substance use disorders, we carry some of that negative countertransference with us into our next and future patient encounters because of the challenges of dealing with some difficult patients. So we then, unfortunately will, have those negative attitudes get conveyed in the way we ask questions. So we really do need to monitor our own feelings, our own attitudes towards patients, which, at times can be very frustrating. And as I said, when I have a non-compliant patient or a patient who's really struggling and relapsing continuously, I have to really monitor my own attitude as well. But also think about the tone of your voice and how you ask the questions. Direct questions are always the best. Do you use, or have you ever used, but I would split those. Do you use alcohol or other substances? Or follow up with, have you ever used alcohol or other substances? And if the patient says yes, then you want to get them to talk a little bit about their pattern of use and what the consequences of their use are, and particularly whether they've had any withdrawal symptoms. We also need to understand who are the high-risk folks, what makes patients high risk for substance use disorders. And family history and prior substance use clearly are very important indicators that we need to pay attention in our particular patient. There's still a lot of social stigma associated with substance use disorders as well, and so that plays a role in how we ask the questions. And again, we have to think about what our attitudes are towards patients with substance use disorder. Next slide. So just take a minute to talk about what addiction is. It is a developmental brain disease that's expressed as compulsive behavior through continued use of a substance or, other behaviors, in fact, like gambling, despite the negative consequences. And it's important for us to remember that it is a chronic disease of brain reward, of motivation, of memory, and related circuitry. And it has a very strong genetic component to it. And what we see are dysfunctions in the circuits that lead to both biological, psychological, social, and spiritual manifestations in our patients. And thus it's reflected in the individual pathology we see as patients try to renew or relieve their pathology by substance use or other negative behaviors. Next slide. So this is a slide that I actually got from a colleague at the National Institutes on Drug Abuse, and I keep multiple copies in my office. I hand it out to trainees. I have it in our group room when I do group sessions with the patients. And I talk to patients, and I sometimes give this to patients if they want it, because it's a very sort of colorful way of thinking about substance use. And, I don't get into, the amygdala or the hippocampus at all. I talk about that central part of your brain where your impulses come from, whether it's impulses to use drugs, to eat, to have sex, to do other pleasurable things, and how those impulses go to the part of the brain called the prefrontal cortex. And we talk about the importance of the prefrontal cortex in determining whether you decide to use a substance or not. And, many people who are in recovery from, one substance will say, well, I'm not somebody who has a big problem with marijuana, so it's okay for me to smoke marijuana once in a while or to drink alcohol because my primary substance has been cocaine or it's been an opioid. And what I remind them is that if you put your prefrontal cortex to sleep, then you can't make good decisions about using other things, and it frequently leads to relapse. So it really does help patients, I think, kind of understand the biological nature, the structural nature of their illness, and I think hopefully it increases their interest in treatment. We also talk about how medication-assisted treatment can help dampen the impulses that are coming from the central part of your brain, and how addiction treatment is very important in terms of almost building that prefrontal cortex up as a muscle. Okay, let's look at the next slide. So, in terms of prevention, we really want to identify patients that are at risk for substance use disorder. So what are some of what I call red flags? I mentioned prior history, and particularly an early history of substance use. People who start using substances in their very early teens, sometimes even before. I certainly see patients who, walked around picking up half-used glasses of alcohol in their households when they were 6 and 7 and 8 years old. Looking at job performance, school issues, have there been any developmental problems? Have they lost jobs? Were they in special classes? Or did they have behavioral problems as they went through their educational training? Family history is really important. This is an intergenerational disorder, and it's very clear that family history plays a huge role in the development of substance use disorders. And certainly many of the patients that I see are patients who were exposed in utero themselves to their maternal substance use. And frequently patients know that when they tell you that their mom or their dad or there was alcohol in the household or cocaine in the household, they frequently know that parent that mother used during her pregnancy. I mentioned developmental issues in terms of school and job performance, but also ongoing trauma or developmental trauma. An early history of physical, emotional, or sexual abuse is going to make somebody much more vulnerable to substance use disorder. And then co-occurring psychiatric disorders. In women, about 80% of women have a co-occurring psychiatric disorder. It's probably more like 60, maybe 70% in men. And frequently, patients will use substances to self-medicate a primary psychiatric disorder. Patients with chronic pain complaints. And then as you look, at the physical exam, you clearly want to look at signs and symptoms that may give you a clue that the patient is using substances. Alcohol in their breath, or, a lot of mouthwash just before coming in to see you. Patients with chronic GI complaints, obviously hepatomegaly, patients with nasal ulcers, tract marks, skin that's excoriated from scratching, patients that complain of weight change, tremors, abnormal speech patterns, and of course in pregnant women, premature labor. And then looking at labs, particularly LFTs and enzymes. And then, as part of the social history, which is, of course, very important, is looking for social isolation, having a legal history, whether it's an arrest for a DUI or incarceration for possession or a variety of other things. And then another huge red flag is somebody who has a chronic medical illness, and the co-occurrence of chronic medical illnesses is very high in patients with substance use disorder, is medical noncompliance. So if the patient's got hypertension and they're not taking their antihypertensive meds, or if they have diabetes and their diabetes is poorly controlled, these are all signs and signals that the patient is at high risk for having a substance use disorder. Okay, so what are some of the challenges in assessing patients? Because it is hard to do an unbiased clinical assessment. And I put this little inclusion in the slide that looks at the comparison of substance use disorders with other common medical illnesses, because we sometimes forget that substance use disorders are no different than working with patients who have diabetes or hypertension or other asthma, other medical problems. The relapse and recovery rates are very, very similar for each of those illnesses. So I see this slide as a nice reminder that we need to remember that this is a chronic illness that does have its relapses. So what are those challenges? Well, we've all been burned. We've all had negative experiences with patients with substance use disorders. And so, as I said, the countertransference can sort of come over and create problems. It feels like it takes too much time to ask that history. And of course, if it's part of the social history and you've just gotten through a complicated medical history and you've got an office full of patients that, are backing you up, then you sort of think, well, we'll get to it next time, or we may not ever get to the social history. It's not so important. But we do need to know that there are potentially life-threatening consequences to substance use disorders, and we sometimes threaten patients with that, which, is pretty scary for the patient and can frequently scare the patient away from following up with you. So we have to be very careful about how we phrase that information, and asking the patient, what they think the consequences could be is always a good way to start. Clinicians frequently tell me they don't know what to do if the patient says, yes, I do, and I want help. So that knowing and being knowledgeable about what's available in terms of help is very important. We all have concerns about drug-seeking patients. I do a lot of medication-assisted treatment and worry all the time about whether my patients are diverting their Suboxone. We have them sign contracts. We go through a lot of consenting and monitor their use of their Suboxone, but it's still, always an outside worry, and we have to, sometimes just trust patients and know that it's more important to reduce risk than to not give patients treatment. Also, clinicians have a poor understanding of the disease model of substance use disorder, and even a poor understanding of what substance use treatment is and the outcomes. And of course, being able to understand the role of co-occurring psychiatric disorders along with medical disorders all add to the challenges. And I think, unfortunately, and I probably say this elsewhere too, but I'll say it now, we get trained as part of our training that 12-step programs are helpful for patients with substance use disorders, and there's no question that they are helpful, but they're adjunct. They are not evidence-based practices. And so we need to keep that in mind and not simply refer people for a 12-step program, AA or NA, but rather to make sure they're getting substance use treatment along with the adjunct of 12 steps if that's something they're comfortable with. So what are some of the principles of the unbiased clinical assessment for substance use disorders? First of all, remember that patients are fearful about how you're going to react if they acknowledge their substance use. So it's important to be very careful in how you address the patient and not convey a negative attitude. Obviously, understanding and evaluating the complex etiology of their illness, the impact of substances on the brain, the role of co-occurring psychiatric disorders and their need for treatment, the history of trauma, and then other environmental factors. Patients who are struggling frequently are living in situations where other people are using as well, whether it's the social situation. Obviously, we've been hearing a lot about that in the Supreme Court hearings recently about how, substance use in adolescents, particularly alcohol use, was a very common thing that was happening. So it was quote unquote okay. So we have to keep those environmental factors. Addressing our own biases, our own countertransference is really very important. Direct questions, as I said, are always best. We've talked about that. So what about dealing with drug-seeking patients? That's the next slide, I believe. These are the patients that I think, challenge us the most in many ways. And so it's important to, remember that your patient is in pain. They're coming to you because they need help. It may be emotional pain or the way they are perceiving their physical discomfort and their physical pain, which may be exacerbated by emotional issues or psychiatric issues. So it's important to always be respectful and empathic with the patient. It may take some time to engage your patient in treatment and to help them understand that they in fact do have a substance use problem. And point out your concern when you're, talking to the patient. Let them know that you hear their frustration, how hard it's been for them, to really be empathic and to create an empathic situation. But it's also important for you to, as you're talking to the patient, to create a differential diagnosis about why the patient is behaving the way they are. And don't assume anything, and frequently ask the patient, help me better understand, why this is happening. Because we don't know always what's going on in the patient's head. And then, using a narcotics contract with the patient. And there's, I think, a very good example of that in the .com module. So I'd encourage you to look at that and spend some time understanding how to create a narcotics contract. Knowing what brief intervention is. First of all, it's really important to know that treatment works. Patients get better. Addiction treatment is evidence-based, and unlike 12 steps, for which there is no evidence, that doesn't mean it doesn't help, but it's not an evidence-based practice. But addiction treatment is evidence-based. It's expected to be evidence-based. Not that there aren't some charlatans out there, but that's true in every aspect of medicine. So remember that engagement can be a long process. It requires us being patient with our patients, being clear in our communications about diagnosis, again, being direct, non-judgmental, and empathic. We want to address readiness to change. Where is the patient in their willingness to get some help? And also, of course, we're assessing the level of severity. Is this somebody that may have some interpersonal issues because of their substance use, or is it somebody that's in liver failure because of their chronic alcohol use? You want to make sure you're maintaining contact with the patient and providing the best medical care you can with them during their substance use treatment. It's very important for patients to understand that you're not rejecting them, that you're going to be there working along with their substance use disorder treatment team to make sure that their diabetes or their hypertension, their asthma, their COPD is going to be addressed, and you're going to be there for them. Making sure that you are referring patients for co-occurring psychiatric disorders. Many substance use programs have an on-site psychiatrist, others refer out, but you want to make sure that if there is a co-occurring psychiatric disorder, which is common, that's getting addressed. And ensure that you're following safe prescribing guidelines and collaborating with other specialties, while maintaining open communication with the other specialists as well as with your patient. And it's critical to convey optimism about recovery, because we do know treatment works and we do know that people recover. There are some, I think, wonderful resources out there that have only gotten better in light of the opioid epidemic. The National Institute on Drug Abuse, has some wonderful resources. There's a section called NIDA-Med for professionals, and I would certainly encourage you to access that. The Substance Abuse and Mental Health Services Administration, SAMHSA, has great resources for you. And then the .com modules are wonderful resources as well. So I think I've kept right inside my time frame.
Thank you, Barbara, for that very, very important information. And let me just talk a little bit about evidence-based importance of communication skills. There's a lot of proof out there that communication skills work. It avoids medical outcomes. It improves medical outcomes, I should say, decreases malpractice claims, enhances physician-provider satisfaction. And it's also showing that HCAP surveys and scores improve, because there are 2 communication dimensions on HCAPs, the patient satisfaction surveys. And if you get high communication scores, then you get high overall scores. So before I get to our offer of having a 30-day free trial subscription to .com, let me just describe it a little bit. We have 42 very interactive modules, each about an hour in length. We have over 40 CME, MOC credits. Everybody loves our over 400 realistic videos that we have, and we have lots of faculty resources as well, if you're in a medical school or a teaching environment. A sample module consists of a rationale, key concepts, a behavioral checklist, references. Here's an example of an annotated video where the learner watches what's being said on the panel on the right while listening to what the clinician, the patient, is talking about. We have a number of comprehension scores. This one is to increase empathy understanding. And it's also used to identify people who might need remediation skills as well. You listen to the conversation where the physician doesn't have an empathic comment, and you click where an empathic comment should be made, actually. Here's one on facial recognition. As the face comes up, click on the box as to which emotion it's displaying, and then it's shuffled and goes down to 3 seconds and then 1 second. We have a lot of resources, facilitator guides, syllabi, administration guide. Our free resources include over 20 webinars that we've done, things like balance and self-care, responding to strong emotions, delivering bad news. And we also launched a podcast this year. We've had over 4,800 downloads, and more than 30 episodes have been released. That's the logo up there. It's called Healthcare Communication Effective Techniques for Clinicians, and you can find it on iTunes, Stitcher, and wherever you get your podcasts. They're 25 minutes in length, which is the average commute time in the United States, and research shows that most podcasts are listened to either through commuting or exercising. Our most popular download is Think and Communicate Differently, New Approaches to Meetings. And after interviewing Kathy Risden on that subject, I actually changed the way that I facilitate meetings. So please check out our podcast. We have one hospital that has actually sent the link to all of their physicians. And here's some information about our free trial subscription. No credit card is required. Just go on to the .com website under subscriptions and put in the code WEBOCT18, and you will get a free 30-day subscription. So thank you again, Barbara, for talking with us.
No, you're very welcome. It's a pleasure.
And thank you to everyone who has joined us. The recording and the PowerPoint will be on our website very shortly. And thank you very much.